Okay, let's try again. So we'll start with our intro, but we'll talk about evaluation of spells and are they epileptic or not. I have no disclosures. And the objectives of my talk will be to review the differential diagnosis of spells, establish features distinguishing episode types, and assess the utility of diagnostic testing for seizures. So when we think of the differential diagnosis, common things that we think about with spells are seizures, non-epileptic or functional seizures, syncope, transient ischemic attacks, sleep disorders, and migraine. We'll start with what are seizures and what is epilepsy. So seizures are stereotyped recurrent events due to abnormal synchronized neuronal firing of the brain. They usually progress quickly, the duration is seconds to minutes, and majority are less than 2 minutes. There's often disorientation following, and then there's a question of, was this seizure provoked or unprovoked? Epilepsy is a disease of the brain defined by any of the following conditions: at least 2 unprovoked seizures occurring greater than 24 hours apart, 1 unprovoked seizure, and a probability of further seizures that's similar to the general recurrence risk of at least 60% after 2, which is similar to having 2 unprovoked seizures separated by 24 hours, that would occur over the next 10 years, or the diagnosis of an epilepsy syndrome. Epilepsy is considered to be resolved for individuals who have an age-dependent epilepsy syndrome, but are now past the applicable age or have remained seizure-free for the last 10 years with no seizure medications for the last 5 years. So if there is a single unprovoked seizures, what risk factors should we consider that would put someone at greater risk of having that second seizure? So the main thing is a prior neurologic insult, which has been shown to be the most powerful and consistent, but prior acute symptomatic seizures, status or multiple seizures at the time of first presentation, a Todd's paresis, which is postictal paresis, family history, particularly a sibling, a history of febrile seizures, a history of any CNS infection, and then seizures out of sleep. So what are the implications of this diagnosis of epilepsy? So, missing the diagnosis, can obviously be a risk of death or even injury if there's status. And there can be a reduced quality of life due to recurrent events. On the other hand, a misdiagnosis of epilepsy also has repercussions, including erroneous use of ASMs, which in themselves could impair quality of life, or just the stigma of carrying that diagnosis and the restrictions that may come with it. It can be potentially fatal because treatment may be escalated for the wrong diagnosis. And it's been shown that 20 to 40% of patients that are diagnosed with epilepsy may not actually have epilepsy. There's also an issue with the delay to diagnosis. So 40% of patients who presented with their first seizure have previously experienced seizures, and we've seen this in multiple studies. So we'll start with this one. This is a study of 220 patients that were diagnosed at the first seizure clinic in Melbourne, Australia. And the index seizure was defined as the seizure that led to medical attention. And so of these 220 patients, their initial seizure leading to medical presentation was convulsive in 85%. It was disruptive in about 78%, did cause minor injury in about 34%, and almost 6% had motor vehicle accidents. But the most interesting part I thought was that 41% had 1 or more prior events, and they delved into those 90 patients further, and about 50% of those had more than 5 multiple prior events before presenting to medical attention. And about 28% had 1 or more convulsive episodes previously, 66% had a disruptive event, and about 2% had motor vehicle accidents. They also found that the delay from the first event to presentation was greater than 4 weeks in 36% of patients, and greater than 6 months in 21%, and greater than 2 years in 14%. And non-convulsive seizures were the first event. Non-convulsive first events were strongly associated with delay to presentation, as was socioeconomic disadvantage. So this is a study from the Human Epilepsy Project of the first iteration that enrolled patients that were newly diagnosed with focal epilepsy, and patients had to be enrolled within 4 months of initiating an anti-seizure medication. And there were 447 total participants, and in this paper, it particularly looked at ED presentation. And of the 201 patients that had motor seizures or convulsive observable seizures, 134 of them did present for the first time to the ED with their first motor seizure. On the other hand, there were 246 participants that had non-motor or non-convulsive seizures, and 117 participants had prior non-motor seizures, but only presented to the ED and got diagnosed after their first motor seizure. So they had been previously having seizures and went undiagnosed until they had that motor seizure. And what are the repercussions of that? So typically we think of convulsive seizures as being dangerous and can cause a lot of problems. And in fact, of the 201 that had motor seizures, 99 had reported prior injuries, with 79 of those being minor, but 4 major injuries, and 4 had had motor vehicle accidents. But even with the focal non-motor seizures, 100 participants reported injuries prior to their diagnosis. 70 had minor injuries, but 2 had major, and 19 had motor vehicle accidents. And I think this is, particularly important in light of, I know the AAN recently put out new guidelines about driving laws and restrictions. And so a lot of the patients, when they're undiagnosed, are in their highest chance of having that other seizure. So really important to get that whole diagnosis, and they're often not coming to epileptologists, but rather to the ED or their primary care even, maybe not even a neurologist yet. So the history is super important. Talking about the differential a little bit, TIAs often have negative symptoms and don't have a preceding positive phenomenon, and patients are typically aware of their deficits. They have cardiovascular risk factors, and they're unlikely to present as recurrent stereotyped episodes generally. With migraines, you will often have a visual aura, headache, nausea, vomiting, though you can have decreased levels of consciousness or inattention that can be associated with basilar migraine, and the duration is usually much longer, hours to days. Sleep disorders, you just heard a great talk about that, but they're often last more than 10 minutes. There are multiple events per night. They can be variable complex behaviors. Patients can leave the room and they may have coherent speech but no recall. Syncope, which we'll come back to a little bit, is often the biggest on the differential when you're thinking seizures versus syncope. Syncope can often have situational triggers, things like fear, pain, micturition, valsalva, pre-syncopal symptoms like tunnel vision, dizziness, palpitations, orthostasis. The duration is usually very brief, seconds, and there's often no or little disorientation following. For non-epileptic events, you can often have retained awareness despite generalized shaking. Eyes are often closed. You can see hip thrusting, side-to-side head movements, crying, and the duration is often much longer than typical seizures and can last 5 to 30 minutes. In this paper, they looked at transient loss of consciousness between episodes, which usually is going to be either seizures, non-epileptic events, or syncope, as they account for 90% of those episodes. And the objective was that what is the diagnostic potential of a questionnaire that focuses on transient loss of consciousness of events associated with symptoms that could help to differentiate these. They compared patients with proven epilepsy, non-epileptic events, and syncope, and patients self-reported on an 86-item questionnaire using a 5-point Likert scale. So across the cohorts, the age, you see that those with syncope were a little bit older. The age of onset was a little bit younger in the epilepsy group. The duration was longer in the epilepsy group in terms of how long they had been suffering from epilepsy versus syncope or non-epileptic events. The number of episodes in the last year were very high for epilepsy and non-epileptic events, but for syncope, significantly lower. Similarly, for hospitalizations and intensive care admissions, epilepsy and non-epileptic events had kind of similar numbers, but there was far fewer in syncope. And then, interestingly, family history really didn't differ between all 3 groups. So when they looked at the significant responses overall, the non-epileptic group reported more frequent symptoms overall than those with epilepsy or syncope, and they were associated with a wider range of symptoms, and they were less stereotyped. So responses to 57 symptoms differed significantly among the 3 diagnostic groups. The questions were then grouped into 5 main factors and scored. Things like feeling overpowered, sensory experience, amnesia, mind-body world disconnection, and catastrophic experiences. And non-epileptic events had the highest rates of symptoms categorized as disconnection or catastrophic. So the combination of factor scores and basic patient demographic clinical information correctly classified more patients than the symptom-based data alone, and multinomial logistic regression analysis revealed 91 out of 100 syncope diagnoses could be predicted correctly, and the correct classification rates were lower for epilepsy, about 66%, and 78% for non-epileptic seizures. So in this same cohort, they focused on 7 of the 86 questions, like feeling frightened, something terrible might happen again, frightened I'm gonna die, I will lose control, will go crazy, feel shaky and sweaty, or feel like I have to get out of this situation. And they concluded that the frequency of the panic-related attack symptoms can help distinguish non-epileptic events from epilepsy and syncope, but not epilepsy from syncope. So this was a different group that did a retrospective analysis of patients diagnosed with non-epileptic seizures or epilepsy based on video EEG and investigated the 13 DSM-4 panic criteria between the 2 groups. And statistically, a higher mean number of symptoms were reported by patients with non-epileptic events compared to those with epilepsy. We often try to differentiate syncope versus seizure with tongue bite and urinary incontinence. And while there are higher rates of tongue bite in epilepsy versus syncope, it's really a lateral tongue bite that was more specific. And urinary incontinence, at least in this study, really didn't have any value in differential diagnosis. And for the evaluation, the things you may consider depending on your differential may include EKG, Holter loop, tilt table, polysomnography, vessel imaging, and then we'll talk a little bit more about MRI, EEG, and now smartphone video. So remember that with any diagnostic testing, you want to interpret it based on your pretest probability. So let's start with MRI. MRI showing detection of potentially epileptogenic lesions is generally considered to be associated with a high seizure risk of greater than 60%, and several studies have reported a 2 to 2.5-fold increased risk in patients with evidence of preceding brain lesions like stroke or CNS infection. Following a first cavernoma-related seizure, the 5-year risk of epilepsy was 94%, and after a stroke, the risk is higher with cortical involvement after cerebral hemorrhage and location in the anterior circulation. So with this study, they looked at 740 patients with MRI and EEG data who presented to a first seizure clinic over a 10-year period, and potentially epileptogenic lesions were detected in 23%. Most commonly, the types of lesions found associated with focal seizures were gliosis or encephalomalacia, followed by tumors, cavernomas, and mesial temporal sclerosis. Epileptogenic lesions were seen in 53% of focal epilepsy patients, but about 13% of generalized onset seizures and 38% of uncertain type. And the frequency of potentially epileptogenic lesions was 28% in patients diagnosed as having an epileptic seizure, but also 8% in those with a non-epileptic event, and in 53% of those that had focal onset seizures. So again, you want whatever the lesion is that you are seeing to be concordant with the semiology that you see to be more certain, and the location to be more certain that that is what's contributing to the seizures. In terms of EEG, assuming a pretest probability of 50%, epileptiform discharges on a routine EEG after a first unprovoked seizure had a 66 to 77% probability of having a second seizure. And EEGs with sleep deprivation can sometimes reveal epileptiform discharges in 13% of patients who had no epileptiform activity on a standard EEG. I think one thing to remember is, among those with epilepsy, the cumulative yield of epileptiform abnormalities was 53% after the first EEG study and 72% after the third. And among those with a single unprovoked seizure, the cumulative yield was 39% after the first routine EEG and 68% after the third. And that's why we'll often do an ambulatory EEG off the bat so you have more prolonged monitoring, or certainly if your routine EEG is negative and you have a high suspicion that that event was a seizure, you should get a more prolonged monitoring. EEG is the gold standard diagnosis for epilepsy, and to correlate that clinical electrographic correlation between the behavior and the EEG electrical activity. However, that requires capturing the event while they're on EEG, and realistically, those recordings are often inaccessible to many, and even for those that we can get into an EMU, we may fail to capture the attack, and we do in about a third of patients. But now we have smartphones, and as Dr. Bilazil said, many patients are already using this. And this was a quote that was not mine, but I liked, that was, smartphones allow most of the population to own half an EMU. And it can, and it does, we have papers that shows that it can be done safely by witnesses. It does increase diagnostic accuracy, as you saw in the previous talk. Having the history is great, but that video definitely adds a good bit, and it's very powerful when it's reviewed by a trained epileptologist or sleep person or movement, and someone who's used to seeing those types of spells. And it increases the probability of capturing the event because you're not limited to the time that they're in the EMU. And here we have a QR code that we use that connects you to some of the resources we give our own patients. On our website, we have a video that's also captioned in Spanish that tells family members, how they can safely record the event and bring it in and what they can ask, as well as handouts in Spanish and English that we hand to patients, and they've been pretty receptive. And we did have a poster here earlier asking about patient attitudes, and most patients were actually, we're happy to have it be an addition in their diagnostic options. So we'll look at just a few cases here. So many of you may have seen this video, but this is convulsive syncope, where they hyperventilated. I believe there were med students back in the day. And you can see, we can play it one more time. You do see a few movements here, and there is some convulsive movement. And the history you may get is that they lost consciousness and had full body shaking, whereas this does not look like a tonic-clonic seizure. This video, we'll try it, but oh, it's working now. Okay. So this is a 64-year-old who was having these events about 10 times a day, had no loss of awareness, but reported a mental block with it. And the episodes mainly occurred upon standing from a supine position or when walking. So it turned out they had a left ICA stenosis, and this is a limb shaking TIA. Oops. Okay. There we go. So play this one now. So in the first part of the video, you see a typical episode while he's seated. There's humming noises during the spell, a small smile at the end, and in the second part, he has another typical spell, but while standing, and he has these marching movements and arm swinging during the events that are, again, stereotyped, and these were frontal lobe seizures. So I think it cut the beginning, but you can see he has aversive left head turn. He was doing a video to begin with when this happened, but you can see how far he's turning. Now you see some blinking, some dystonic posturing in his arm. He's saying something is wrong with me. So this is a focal impaired, he later loses awareness and it becomes a focal impaired aware seizure. So key points to consider when making a diagnosis of seizures, the history again is very important, and particularly you may want to pay attention to symptoms of panic, depersonalization, catastrophe. If there's retained awareness with bilateral shaking, those things all may suggest non-epileptic events. The age of onset, duration, frequency, and number of symptoms can be helpful. A lateral tongue bite is more specific for seizures than any tongue bite. Remote symptomatic etiology suggests seizures, and with EEG, epileptiform discharges specifically are more predictive than slowing, which is nonspecific, and you have increased yield with 2 to 3 routines and possibly sleep deprivation. MRI having an epileptogenic lesion makes it more likely that there's going to be a recurrence, and then a normal EEG and MRI with non-focal features and semiology should definitely lead to consideration of further EEG monitoring to solidify the diagnosis. Thank you.